Dear students, today we shall be discussing on different nasal septum conditions like deviated nasal septum (DNS), septal hematoma, septal abscess, and septal perforation. Deviated nasal septum, also called DNS. The etiology of DNS is traumatic. When the patient has any form of trauma in the face or in the nose, there might be DNS. Developmental, by developmental insults like birth molding phenomena, high arch palate, unequal growth between the skull base and palate also leads to DNS. Mass in the opposite nasal cavity leads to DNS to opposite side. Racial factors like Brahmins or Aryans, posterior DNS is supposed to be due to hereditary conditions. What are different types of DNS? DNS can be classified as anterior or caudal dislocation, C-sept deviation, S-sept deviation, septal spur, which is self-like projection between the bone and the cartilage, and septal thickening, which is due to organized hematoma when the patient develops septal hematoma or overwriting of septal fragments like duplicated nasal septum. You can see different types of DNS over here in the picture. This is caudal dislocation. The septum has to rest over here in the maxillary crest, but it is going towards more left side. It's called anterior dislocation of the septum or caudal dislocation of septum. This is C-sept deviation. This is S-sept deviation. This is spur touching the turbinate. This is inferior turbinate and thickening of the nasal septum. For surgical purpose, DNS can be classified as Cottle's classification, which states that simple DNS means DNS which is not causing any problem to the patient. It is basically incidental finding. Around 90% of all the people, they have some form of DNS either to right or towards left side. Second is obstructed DNS. DNS causes nasal obstruction, but that opens with use of decongestants. Impacted DNS. DNS causing nasal obstruction that does not open even with the use of decongestants. So, patient requires surgery for obstructed and impacted DNS, and patient does not require surgery for simple DNS. As I already told, around 90% of all the people have simple DNS. So, around 90% of people do not require any surgery for deviation. What are different clinical features of DNS? They are nasal obstruction, which is the most common clinical feature. Usually happens on the side of DNS due to deviation. You can see here, this is the deviation. So, patient will have right side nasal obstruction in this case. And there is next term called as paradoxical nasal obstruction towards the opposite side due to compensatory hypertrophy of the inferior turbinate. And what is the paradox? The paradox is that patient is not aware of the obstruction on the deviated side because, as you know, patient is having obstruction for a long time due to DNS. And as the patient develops common cold or rhinitis, then the patient will have obstruction on the opposite side also. So the patient thinks that they have obstruction on left side in this case, as the patient is always having obstruction to the right side, which is not noticed by the patient. That is called paradoxical nasal obstruction, and is due to compensatory inferior turbinate hypertrophy on the opposite side. Recurrent cold might be due to sinusitis or allergic conditions. Headache due to Slaughter's neuralgia or sinusitis. Slaughter's neuralgia is neuralgic pain which happens due to pressure of inferior turbinate or middle turbinate by the spur. In this case, you can see there is a spur, septal spur touching the inferior turbinate is almost impinging, so patient will have severe pain in and around the orbit and in the face. That is called Slaughter's neuralgia, so-called anterior ethmoidal nerve syndrome. Epistaxis might happen due to stressed mucosa on the side of DNS, which leads to crusting and bleeding on removal of the crust, or stressed blood vessels over the spur might lead to spontaneous bleeding or bleeding when the patient touches or when the patient tries to clean the nasal cavity. Hyposemia might happen due to high deviated nasal septum. There might be external nasal deformity also. As the septum goes, so goes the nose. When the patient is having deviation to right or left side, the external deformity also might be there. Deviated nasal septum might lead to different sequelae like sinusitis, mouth breathing, snoring, pharyngitis, atrophic rhinitis, and myiasis towards the opposite side of DNS due to big nasal cavity Although most of the times this is theoretical part only, and sometimes otitis media due to sinusitis or stitching tube block. Having noted all the clinical features and sequelae of DNS, let's go to indications for septal surgery. The most important indication for septal surgery is DNS, leading to nasal obstruction, sinusitis, headache, or epistaxis. We also perform septoplasty along with rhinoplasty, so-called septorhinoplasty. Septoplasty is also performed for harvesting of the septal cartilage graft, transseptal root, for surgery of the pituitary fossa, that is hypophyseectomy, or for BDN neurectomy, and for hereditary hemorrhagic telangiectasia. What are the commonly performed surgeries to correct the deviated nasal septum? The commonly performed surgeries to correct DNS are septoplasty and submucosal resection of the septum, so-called SMR surgery. In present-day practice, septoplasty is the most commonly performed surgery for the nasal septum, and it is one of the most common surgeries performed on the nose all over the world. Cottle's line is important during septal surgery. Cottle's line is an imaginary line drawn from the frontal nasal spine to maxillary nasal spine. This is very important. See, you can see here, this is the frontal nasal spine. This is the nasal spine of frontal bone. This is the frontal nasal spine. That means this is the nasal spine of the frontal bone. This is the frontal bone and this is the nasal spine joining the maxillary nasal spine. Therefore, this line, which joins the frontal nasal process with the maxillary nasal process, divides the septum into anterior septum and the posterior septum. So any deviation which is anterior to this line is called as the anterior deviation and can be only corrected by septoplasty surgery. And any deviations which is posterior to it can be either corrected by SMR or by septoplasty surgery. Because during SMR surgery, we have to at least leave some dorsal and the caudal strut, that is around 1 into 1 centimeter of the dorsal and caudal strut. So if we perform SMR surgery anteriorly, we cannot leave the dorsal and caudal strut. Therefore, SMR surgery is contraindicated for anterior dislocations or anterior deviations. But for posterior deviations, SMR can be performed, and septoplasty can be performed for anterior as well as the posterior deviations. You know, septoplasty surgery is one of the conservative surgery, and SMR surgery is one of the radical surgeries. How to differentiate between septoplasty and SMR surgery? This is very commonly asked question in the exam. Septoplasty surgery is one of the conservative surgeries, whereas SMR surgery is radical surgery. The age in which septoplasty surgery is done is after 4 years. Even though you can perform septal surgery below 4 years also, but usually not done before 4 years. But SMR surgery is not performed below 17 years because the nose still grows till the age of 17 years and you cannot do radical surgery for the nose till 17 years of age. Incision for septoplasty is Freer's incision, and that for SMR surgery is Killian's incision. Septoplasty corrects both anterior as well as posterior DNS, whereas SMR surgery cannot correct anterior DNS. Flap elevation in septoplasty is in one side only, and flap elevation for SMR surgery is bilateral muco-periosteal flap. Only inferior strip of cartilage is removed in septoplasty in most of the times, but we can remove the spur also. But in SMR surgery, it is a radical removal of the septal cartilage is performed. Rhinoplasty can be performed along with septoplasty, also called as septorhinoplasty, but SMR surgery, rhinoplasty cannot be combined with. Revision surgery is relatively easy in cases of septoplasty because it is one of the conservative surgeries. In SMR surgery, revision surgery is relatively difficult because we remove most of the part of the nasal septal cartilage and bone. The cartilage graft can be harvested during SMR surgery. Because it is a radical surgery, we can take a big chunk of the cartilage and bone. Complications of septoplasty are rare, but complications by SMR surgery are common because it is one of the destructive surgery or radical surgery. Coming to septoplasty surgery, incision for septoplasty is Freer's incision as already told, and it is made on the caudal border of the cartilaginous septum. This is the caudal border of cartilaginous septum, and the incision is made here. It is called Freer's incision. You can see the incision is being made with the 15 number blade over here. Once we make Freer's incision, we use the elevator to elevate the muco-periosteal flap on one side. So the creation of anterior and the inferior tunnels is made. Okay, you can see more clear. This is anterior tunnel here and this is inferior tunnel. Anterior tunnel is the muco-periosteal tunnel, and the inferior tunnel is the muco-periosteum. This is the muco-periosteum. So this is the muco-periosteal flap. Okay, periosteal flap raised on the opposite side, and this will be cut. We'll cut with the knife, and we'll join the anterior tunnel with the inferior tunnel on one side, and we'll elevate part of the flap on the opposite side, and we'll just remove the part of septum which is deviated, usually the inferior strip. And now dislocation of the bony and the cartilaginous junction is performed. This is the quadrilateral cartilage, and this is the ethmoid bone. Then muco-periosteal flap elevation on both sides is performed as already told. So on both sides, here you can see this is dislocated, and this is also dislocated. Therefore, they're like open book or open door technique. So now we can easily remove the inferior strip of the cartilage. So this cartilage is removed, and the cartilage is kept in the midline. Now if there is any spur and deviated portion of the cartilage, they are also removed. The floor of nasal septum is also removed. See, this is the maxillary crest. This is the maxilla, okay, part of the palatine bone, and the maxilla is removed. So the septum becomes straight. As you know, the cartilage has its memory. Therefore, scoring and cross-hatching or wedge excision and saving are performed to lose the memory of the cartilage. So there are less chances of re-deviation of the septal cartilage. Scoring and cross-hatching are performed on the concave side, and wedge excision and saving are performed on the convex side. This you should know, you might be asked in the exam. Now anterior nasal packing is performed just for support, but nowadays we don't use the conventional packing. We either use mucosal pack or we don't pack the nasal cavity at all. Now once packing is done, then bolster is applied for the support of the nasal pack. Now let's go to submucosal resection. The incision for submucosal resection or SMR surgery is Killian's incision, which is performed around 5 mm beyond the caudal border of septal cartilage. So this is the caudal border of septal cartilage, and this is around 5 mm beyond. So this is the caudal border, and this is 5 mm posteriorly. Freer's incision was made here at the caudal border of the septum. Then again, same thing, muco-periosteal flap elevation is performed, and cutting of cartilage and elevation of the opposite flap is performed on the SMR surgery, which is not performed in septoplasty surgery. Here are two important things to remember. One is the incision, which is slightly posterior in comparison to the septoplasty surgery, because you have to leave some form of caudal strut. This is required. So if you make incision here, you cannot leave the caudal strut. So this cutting is also performed around 5 mm beyond the Killian's incision. So cutting of the cartilage and cutting of the mucosa should not be in the same plane, otherwise there might be perforation of the nasal septum. Therefore, to avoid that, we make incision around 5 mm posterior to the caudal border of the septal cartilage, and 5 mm posterior to that the cartilage is incised. So this whole chunk of the cartilage is removed. Ballenger's swivel knife. L-shaped dorsal and caudal strut are left. Otherwise, most of the bone and the cartilage are removed to avoid the settling of the septum or septative deformity, and there will be no columnar retraction also. If we don't leave this, there will be columnar retraction and septative deformity. So avoid that, we perform the leaving of L-shaped and dorsal and the caudal strut, or at least one same each. And the Ballenger's swivel knife removes whole of the septum. This is the remove the septum by Ballenger's swivel knife. Now you can see here the bone and the cartilage are removed. This dorsal strut and the caudal strut are left. This whole part is removed. Then we do anterior nasal packing as in septoplasty. SMR surgery is not usually performed nowadays. Coming to complications of septal surgery. What are the complications of septal surgery? Complications might be hemorrhage or hematoma formation, infection or abscess formation, or perforation of the nasal septum. In sudden nose, suppurative depression or columnar retraction are common while performing SMR surgery. Flapping septum, one of the complications by SMR surgery. Persistent deviation, complication of septoplasty surgery. Nasal synechia might be in both the cases when there is extreme trauma to the lateral wall of the nose, including the turbinates. CSF rhinorrhea, when you perform septal surgery or when you just pull the upper part of the septum, cribriform plate of the ethmoid down, or sometimes when you perform conga bullosa surgery. Infection is usually uncommon, but you have to tell the patient to clean the nose regularly. Toxic shock syndrome might happen due to nasal packing. It is less common nowadays. Coming to second topic for today is the septal hematoma. Septal hematoma is defined as collection of blood under the perichondrium or periosteum of the nasal septum. Etiology is nasal trauma, blunt trauma, especially septal surgery like septoplasty surgery and some bleeding disorders. Clinical features of septal hematoma are there will be bilateral nasal obstruction most of the times, but sometimes there might be unilateral obstruction. Sense of pressure above the nasal bridge will be there because of on examination you can see bilaterally smooth, fusiform and round septal swelling. On palpation, mass is soft and fluctuant, so it is difficult to differentiate between hematoma and abscess simply clinically. Absence of raised temperature, erythema, swelling and tenderness of the skin over the nose. This signifies that there is no abscess formation probably. You can see this is the bilateral swelling of the nasal septum. Okay, as you can see the fusiform swelling here. So this signifies this is either septal hematoma or septal abscess. But as the patient is not having any raised temperature, erythema and tenderness, it signifies the patient is having hematoma. Sometimes when the patient is having trauma, then there might be pain or tenderness and thoughts. How to treat septal hematoma? This is very easy. When there is a small hematoma, you have to perform wide bore needle aspiration. And when there is large hematoma, incision and drainage, nasal packing, basically pressurized nasal packing to prevent recurrence, and systemic antibiotics to prevent abscess are to be given. When the patient is having some hematologic problems, then we can use tranexamic acid. What are the complications of septal hematoma? As you know, the hematoma might be infected, leading to septal abscess and cartilage necrosis shall be there. When there is septal abscess and cartilage necrosis, patient might have septal perforation. Perforation of bony septum leads to saddle nose, whereas perforation of the cartilage septum will lead to supratip deformity. There shall be thickened nasal septum due to organized hematoma also. Coming to next topic, septal abscess is collection of pus under the perichondrium or periosteum of nasal septum. Etiology of septal abscess is secondary infection of septal hematoma. Long-lasting hematoma gets infected secondarily following furuncle of nose or upper lip. There might be abscess formation following typhoid or measles or immunocompromised host. Clinical features are bilateral nasal obstruction with fever, skin over the nose shows raised temperature, erythema, swelling and tenderness due to traumatic cause. On examination, you can see bilaterally smooth, soft, fluctuant septal swelling, which is similar like septal hematoma, and congested septal mucosa and submandibular node enlargement. You can see here, this is the septal abscess, and you can see some infection over here, and there is tenderness and it is much swollen in comparison to the septal hematoma. Treatment is by abscess drainage and immediate abscess drainage by making an incision on the most dependent portion. Pus and necrosed cartilage are removed. Nasal packing is performed and systemic antibiotics administered for 7 to 10 days. Complications of septal abscess might be necrosis of the septal cartilage, saddle nose, supratip deformity, septal perforation, meningitis, or sometimes cavernous sinus thrombosis too. Coming to last topic for today, septal perforation. Etiology of septal perforation is trauma like septal surgery, nose picking, septal cautery, or ornamentation. Infections like septal abscess also might lead to perforation of nasal septum. Irritants like snuff and cocaine are the common things in the Western countries. Foreign body, rhinolith, nasal mastitis all might lead to perforation of septum when they are long-standing. Granulomatous conditions like tuberculosis, leprosy, syphilis, Weisner's granuloma all might lead to perforation of septum, malignant lesions, and idiopathic conditions. What are the clinical features of septal perforation? Obviously, you can see perforation of the nasal septum on examination. When the perforation is small, then there might be whistling sound during respiration or basically breathing. Then large perforation might lead to nasal crusting and nasal obstruction and epistaxis and cross removal. You can see the perforation of nasal septum. How to treat the nasal septal perforation? First, treat the cause of septal perforation. There are different causes. You have to treat it. Alkaline nasal douching for removing the crusts. Small perforation might be closed by mucosal advancement flap, whereas large perforation might require Silastic obturator, Hematoma, or surgery, but the results of surgery are poor. As you can see here, this is the mucosal advancement flaps. So this is the mucosa which is advanced. This is a perforation. This is the mucosa is to be advanced here, and this is a mucosa cut here, and this is kept more posteriorly, so to close the perforation. Okay, and you can see the scissor has been here, and you can just advance the mucosal flaps. That is called mucosal advancement flaps. Then sublingual flap also can be taken from the sublingual mucosa and it can be kept in the perforation. And if not, then Silastic obturator can be used to close the perforation, but that is not true surgery. That is simply the implant. We'll finish the class here. Thank you so much for seeing the video. Please subscribe my YouTube channel, Dr. Krishna Koirala, for more useful videos for MBBS and MS ENT examinations, both theory and practicals. Thank you.